Chapter 37, Care of the Surgical Patient by Nakia Henderson, RN, BSN. Lesson 37.1, Surgery Causes, Risk, and Potential Complications. Theory objectives include: discuss reasons for performing surgery, identify potential risk factors for complications of surgery, explain the nurse's role in the various phases of perioperative nursing, illustrate how robotic surgery has shortened recovery time. Theory objectives continued: compare the types of anesthesia used for surgery, verify the safety measures in place to prevent errors regarding surgical site, assist the patient with psychological preparation for surgery. Reasons for surgery: elective, voluntary procedure performed when convenient for the patient, such as when a hernia repair is scheduled a week away. Usually no significant consequences if the surgery is not performed right away. Emergency surgery, often necessary in trauma cases. Serious consequences if surgery is not done immediately. Palliative, surgery that usually relieves pain or discomfort. Diagnostic, to provide data for a diagnosis such as performing a biopsy. Reconstructive, restores function or appearance such as breast implants post-mastectomy. Curative, cures problems such as removing stones from a gallbladder or removing an infected appendix. Patients at higher risk for surgical complications. Infants due to their immature body systems. Elderly due to declines in various function of various body systems. Both elderly and infants are at risk for dehydration or overhydration, as well as difficulty maintaining core body temperature. Systems affected by aging include cardiovascular, respiratory, renal, integumentary, neurologic, and metabolic. These patients require close post-operative monitoring. Other patients at high risk for surgical complications are patients with bleeding disorders, cancer, heart disease, chronic respiratory disease, liver disease, immune disorders, chronic pain, upper respiratory infections, history of abusing street drugs. Surgical risk factors: diabetes mellitus and other chronic diseases, advanced age with inactivity, very young age, malnutrition, dehydration, obesity. Surgical risk factors continued: cardiovascular problems, peripheral vascular disease, substance abuse or alcohol dependence, smoking, regular use of certain drugs such as aspirin, excessive fear. Surgical risk factors key points: diabetes mellitus and chronic disease. Stress of surgery may cause swings in blood glucose level. Wound healing tends to be delayed, causing an increased risk of dehiscence. Liver and kidney disease makes it more difficult to metabolize and eliminate anesthesia and waste products. Dehydration, reduced circulating volume, predisposes patient to reduced urine output, thrombus formation, and increased risk for pressure areas. Obesity. Extremely heavy patients do not breathe deeply and are at risk for hypostatic pneumonia. Excessive fatty tissue is a factor in poor wound healing. Cardiovascular problems are at higher risk for myocardial infarction from the stress of surgery and anesthesia. Peripheral vascular disease. Poor circulation in extremities increase the risk of thrombus and pressure sores on the lower extremities and feet. Anti-embolism stockings or devices are generally prescribed. Substance abuse. Substance abuse may alter reaction to anesthetic agents. Alcohol dependence may cause withdrawal symptoms. Smoking causes increased lung secretions and predisposes the patient to atelectasis and pneumonia postoperatively. Smokers are prone to thrombus formation. Regular use of meds. Aspirin and anticoagulants make the patient prone to excessive bleeding. Corticosteroids reduce the body's response to infection and delay the healing process. See page 734 for the full list of surgical risk factors key points. Perioperative nursing. Care of the patient from decision to have surgery through recovery from the procedure. Preparation for surgery begins before admission. The patient has diagnostic tests done in the days just before the scheduled surgery. Teaching for post-op care must be efficient because the time of stay is short to reduce costs. Common surgical procedure terminology. Lysis, removal or destruction of. Anastomosis, joining of two parts, ducts, or blood vessels. Ectomy, cutting out or off. Oma, tumor or mass. Ostomy, furnishing with a mouth or an outlet. Plasty, revision, molding, or repair of tissue. Pexy, fixation, anchoring in place. Enhancements to surgical technique. Laser surgery. Light amplification by the stimulated emission of radiation. The light beam is converted to heat as tissue absorbs it. Fiber optic surgery allows the use of endoscopes with high-resolution video cameras through a very small incision. Usually involves 3 to 5 smaller incisions for the various scopes, surgical instruments, and camera. Robotic surgery. The robot is operated by a nearby computer while the surgeon views magnified 3-dimensional images of the surgical field on the computer's screen. A second surgeon and assistants are still next to the patient. Anesthesia has been used for surgical procedures since 1840s. There is always a risk anytime a patient is anesthetized. Goals of anesthesia are to prevent pain, to achieve adequate muscle relaxation, to calm fear, ease anxiety, and induce forgetfulness of an unpleasant experience. The 4 stages of anesthesia. Stage 1. The stage of analgesia begins with the administration of the anesthetic agent and ends when the patient becomes unconscious. Hearing is amplified at the end of this stage. Stage 2, the excitement phase. Muscles become tense, but swallowing and vomiting reflexes are still present. Breathing may be held. The environment should be kept quiet during this period. Stage 3, surgical anesthesia state, begins with the return of regular breathing. Vital functions are depressed, eyes are fixed, and reflexes are lost of temporarily depressed. The surgical procedure is begun during this stage. Stage 4, complete respiratory depression. Spontaneous respirations are absent. The patient is maintained by the anesthesia machine, which supplies oxygen and a set rate of breaths. General anesthesia. Administration of an inhalant gas or by medication introduced intravenously. The patient is in a deep sleep with muscle relaxation and unaware of anything. Regional anesthesia. Administering a nerve block such as a spinal, caudal, epidural, or peripheral block. Patient is awake, but the area of surgery is anesthetized. Used for OB procedures or surgery on lower extremities. Unlike general anesthesia, regional anesthesia does not put the respiratory or cardiovascular systems at risk. Commonly used for chronic pain treatment, nearly always an outpatient procedure, often performed by the anesthesiologist. Common nursing interventions include vital signs, assess allergies, pain response, monitor neurovascular function before and after procedure. Conscious sedation uses a local anesthetic at the surgical site plus intravenous system analgesia. Patient may have some consciousness or some recall, commonly used for procedures such as colonoscopy, bronchoscopy, and cystoscopy. Requires close monitoring of vital signs, oxygenation, and urinary output. Local anesthesia, used for minor procedures, tissue biopsies, vasectomies, pacemaker insertion, removal of superficial cysts, insertion of vascular access devices. Patient does not require care in post-anesthesia recovery unit. Preoperative procedures. Autologous blood donation. Patient donates own blood to prevent possible complications of receiving banked blood. Surgical consent. Informed consent is usually obtained by the surgeon. Questions concerning the surgery are usually clarified at the time consent is being obtained. If the patient's statement and consent are incongruent, refer the matter to the surgeon. Preoperative procedures. Physical examination, medical history and physical examination by the surgeon. EKG usually ordered for patients older than 40 years of age. Diagnostic, complete blood cell count, urinalysis, chest x-ray, and electrocardiogram. Surgical site identification must be done before giving preoperative medications to allow the patient to participate. Surgical site identification. 2016 National Patient Safety Goals. Eliminate wrong site, wrong patient, wrong procedure surgery. Preoperative checklist verification process to ensure appropriate medical records and imaging are available. Process must be implemented to mark the surgical site, and the patient should be involved in the marking process. If patient is unsure about site identification, call a timeout and have the operating team verify the correct patient, correct site, and correct body part. Preoperative checklist. Explanation of procedure, patient education and instruction, patient history, informed consent form signed, diagnostic test performed, patient identification, patient dressed and prepared for surgery. Question 1. Mimi's patient is going for surgery to remove part of a tumor that has metastasized and is causing pain. What type of surgery is Mimi's patient having? Question 2. Who is responsible for obtaining an informed surgical consent? The end.